Well, welcome everyone. This is the Crisis Jam episode 197. You can believe that. And we are going to hear today around partnerships driving innovation. Such a great topic. And we've got three amazing speakers, both from Pew Charitable Trust as well as Clear Pathways, Julie Werthmeyer, Alicia Smith, and Cal Jenkins. So before we get into that featured presentation, let's go through including where you can find all of the information, including how to sign up for the jam, and that's at talk.crisisnow.com. So you can register, get weekly reminders, get very cool virtual backgrounds. And I also just want to note that the under video and materials, when you go to view materials, you can access old PowerPoints, you can see old crisis hot seat questions, data corners, goes all the way back to the beginning of the jam, if you can believe that, to 2020, almost 5 years ago that we have been building this community. So thank you for being a part of that. So you can see that we have it broken out by section. You can easily watch the last jam, which I often do. You can see the videos that we showcase, questions, workforce strategies, everything, one-stop shop, talk.crisisnow.com. Make sure that you share that with your colleagues. So switching over to news, we did want to share, this was recently cross-posted on NPR. 988 crisis hotline counselors are sometimes targeted by sexually abusive callers. So this is something that we are aware of. And when I say we, let me introduce myself. I'm Laura Evans, and I'm the AVP for Public Policy and Government Affairs with Vibrant Emotional Health. Vibrant is the administrator of the 988 Suicide and Crisis Lifeline. So we are very aware of this issue that faces some crisis counselors. Let me see before I spend too much time talking myself. Let me see if we have Shy Lewis here, or if we have our friends from Lines for Life here who want to speak to this. Both Shy was featured in this article because it is something that we do take very seriously, and we do have training available to help crisis counselors face this. But no one should have to face being sexually abused or inappropriate content while they are at work. Shy here. Doesn't look like she's joined us just yet, but please do check out this article. And if you do have any questions, if you have something to report, or maybe you have experienced a negative encounter or had a negative experience on the 988 Lifeline, we want to make sure that we are doing some quality improvement. So I will put a link in the chat for how you can reach out to our quality improvement team. Am I missing someone who's ready to speak on that? All right, let's move forward. Hennepin County, that is the county that represents Minneapolis in Minnesota, has just okayed $15 million for a youth crisis stabilization a unit. So this is very important. We know that kids definitely need a safe place to go, a soft landing that is not juvenile delinquent facilities, which are often not the best place for them to receive the help they need. So in lieu of that, the county is expediting a project for $15 million focused in on youth. But again, I think they are utilizing federal funds from COVID supplements and others. So again, it's really important to think about sustainable funding. So that's something that I'm often thinking about in the government affairs side of things at Vibrant, but also want to share when counties are doing great work. So love to see this, and let's ensure that they have sustainable funding and funding for other counties to replicate. So with that, we are moving forward to the crisis trivia hot seat. Right now, we do not have a volunteer, so I'm going to do a call for volunteers. If you'd like to volunteer, please raise your hand, and I will go to the first hand that I see. If not, we can do this as a collective. Anybody want to volunteer for the crisis hot seat? If you volunteer, you do get a hat or shirt, whatever you'd like. Okay. I'm not seeing any hands, so I am going to go and make this a collective trivia question. And this is around Next Gen 911. So Next Gen 911, it's an initiative to modernize the existing 911 emergency communication system. And they will do that by transitioning from analog to digital IP-based infrastructure. Oh, I'm sorry, I think we might have skipped ahead. Well, let's keep going. So Next Gen 911, essentially taking the existing system and giving it an upgrade so that we are using digital internet-based protocols for the new infrastructure for people to reach 911. This upgrade better aligns with contemporary technology, communication technologies. So the question for everyone here, thank you, is what is the primary advantage of implementing Next Gen 911? So why is 911 upgrading their system to this new IP-based protocol? Is it for lower wait times, adding text and videos, reducing overall cost, or ease for increasing number of call operators? Anyone want to put what they're thinking in the chat? Anyone want to talk us through what they may be considering as you answer this one? This got a lot. Okay, we've got Jessica mentioning E. None of the above. She thinks it's to increase reliability. That's actually a good point. But I think there's one that our 911 public safety answering point partners are really highlighting as a primary advantage. So I'm sure reliability is definitely an advantage, but there's one that's a primary. Let's see. Do we have the results of the poll? All right, we've got 51% of people saying adding text and video, 25% saying lower wait times, 9% reducing overall cost. Excuse me, 15% for ease of increasing number of call operators. I'm seeing folks thumbs up your comment, Jessica, for E. Jamie saying supporting moving from digital to digital from analog. Let's see what the correct answer is here. We've got most of the audience saying B. You guys are right. We couldn't stump you. So modernizing 911 includes multimedia communication, enhanced location accuracy, and integrated data sharing. So the case for recognizing 911 operators as first responders likely to gain some momentum with these advantages. And certainly, as you can imagine, maybe easier sometimes to send a text in an unsafe situation or video, pictures, images of an emergency so that can better inform those 911 operators and how to better assist. So we couldn't stump you. Good job, everyone. Unfortunately, I don't know if we could get everyone a hat or a shirt, but if you are interested in volunteering for the hot seat, you do get one of those. So thank you. It is accessible for the deaf population. Thank you, Dana. It's so important that these services are accessible for everyone. It's another good question. We couldn't get you, but just appreciate you all participating. So with that, I'm going to turn it over to start our featured presentation, and I'm going to hand it first to Julie Wertheimer.
Thank you so much, Laura. My name is Julie Wertheimer, and I lead our behavioral health and criminal justice work at the Pew Charitable Trust. For those who are not familiar with Pew, we do make grants, but in addition to grant making, we both fund and provide technical assistance, research, in a number of areas, both domestic policy and internationally on environmental issues. I, of course, am in the domestic policy portfolio. And since 2020, Pew's Mental Health and Justice Project has conducted research and worked with local stakeholders and policymakers to examine behavioral health and crisis care practices across the country. As many of you know all too well, far too many people in crisis often end up in emergency departments or local jails, while we know that behavioral crisis is largely a locally addressed issue, we've come to learn and believe states have an important role to play in making sure there's access to behavioral health care, no matter who you are, where you live, or where you are when you're experiencing a crisis. So we've been working with state leaders, local officials, and national experts across the country to identify policies that can improve outcomes for individuals experiencing behavioral health crises. One of the ways we achieve our work is by working with organizations that operate at both the state and local level, such as the PEGS Foundation, from which Clear Pathways comes, and you'll hear about in a second. We've been partnering with PEGS since 2021. PEGS is a part of our Behavioral Health Emergency Response Initiative that's hosted by and facilitated by the Marin Institute at NYU and works to identify and advance state policy changes and create plans for potential future investments in Texas, Ohio, and Michigan. This initiative spans both public safety and healthcare systems and aims to reduce the likelihood that a call to an emergency hotline involving a person experiencing a behavioral health emergency results in someone being physically harmed, arrested, or brought to an emergency department when not necessary, and increases the likelihood that such a call results in a person being connected to effective community-based behavioral health services. I'm so grateful to be joined by Alicia Smith and Cal Jenkins from PEGS, who have been leading this important work with us in Ohio. Their Clear Pathways initiative is conducting, a 911-988 standard operating procedures pilot that I'm really excited for all of you to hear about today. And with that, I would like to pass it over to Alicia.
Thanks, Julie. Good morning or afternoon, everyone, depending on where you are. So PEGS Foundation is based in Hudson, Ohio, and we are graciously thankful for our founding partners with PEGS Foundation and our additional funding partners from Pew Charitable Trusts and other funders. Our focus is on adults experiencing behavioral health crises, and our goal is to make sure that when an individual does experience a behavioral health crisis, they have a clear path to receiving person-centered help. Our goal is not only to achieve this aim in Ohio, but also across the nation. Next slide. And the way we want to do our work is to collaborate with local, state, and national partners, not only to accelerate the implementation of best practices, but to make sure that there's awareness of the challenges associated with individuals ultimately relying on hospitals and jails as de facto systems for receiving help in a crisis emergency. Next slide. We do our work in 4 key areas: measurement and evaluation, statewide field building, prototype sites, and financing policies. Measurement and evaluation is an underpinning across all of the work that we do. We firmly believe that what isn't measured cannot be changed. And our goal is to make sure that in all of our efforts, we have an understanding of the problem to be solved. Far too often, we end up embarking on solutions that result in the thing to do without any understanding of the baseline, the evidence to substantiate the existence of a problem, and any awareness of whether we've solved the problem or, in fact, exacerbated it or had no effect whatsoever. So measurement and evaluation is an area that we use to understand the overall effect of Clear Pathways, but also to understand the effect of the work that we do across our other program areas. Statewide field building is an example of the work we do to lift up an awareness of emerging and evidence-based practices, to provide an opportunity for peer and collaborative sharing. We find that there are a lot of emerging experts in the field of behavioral health emergency or crisis, as you'll hear me say interchangeably. And we want to make sure that rather than having folks make individual one-off connections to people who are doing places in Ohio or North Carolina or Arizona or wherever they are, that we have a place that those folks can come to learn together. We do that also through lunch and learns that we host monthly and have been doing for the past couple of years, and more recently conducted some learning collaborative with distinct groups of individuals who might be experiencing some of the same challenges. For example, we recently wrapped a learning collaborative of our Ohio Association of County Behavioral Health Authorities, especially related to their huge infusion of funds to create capacity for behavioral health emergency services and helping them understand from each other and from experts across the nation what some of the opportunities were to overcome some of the challenges they were experiencing. Prototype sites, I won't do a huge spoiler alert here because Cal's going to talk about an exciting area of work that we've been prototyping. Actually, the pilot itself started last year, but the groundwork for this started in early 2021. But that's where we test what we think might have legs for the future to sustain. But consistent with our approach around measurement and evaluation, we also firmly believe in testing out strategies, deciding and understanding the impact, and then making adjustments and ideally promoting them at scale. And then finally, financing policies is an area where we use to promote opportunities to make different policies for payment of behavioral health emergency services. Typically, there is a reliance on how other states do things, or how states have done it all along, and without any regard to what might be necessary for creating change in a certain area, especially when we're talking about 24/7 accessibility, rural considerations, things for high and low population needs. So our goal really is to transform how behavioral health emergency services are paid for, and hopefully that's another area we can come back to a future crisis jam and talk about some successes in that space. Next slide. So what we believe is that the entire crisis system should offer not only someone to call, someone to come, and a place to be safe, but also facilitate the identification of needs at the beginning on an ongoing basis, and make sure that there's an endpoint for post-stabilization follow-up, post-crisis follow-up, to make sure that this cyclical pattern does not persist. Our preference, our desire is that we minimize those least preferred pathways throughout this care continuum and reduce the number of the gold bars that you see that represent least preferred. Acceptable is okay, but what we want to try to achieve is optimal care. And what you'll hear a little bit about today when Cal speaks is the work that we've been doing in that local hotline warm line column related to 911 and 988 coordination. Next slide. Some select accomplishments for 2024. I already mentioned the learning collaborative that we did for our OACBA, our trade association representing the alcohol, drug, and mental health boards. I referenced the work that we've been doing on the Lunch and Learn series for a couple of years. We recently wrapped, as recent as Friday, a very exciting local systems assessment approach in one of our large urban counties here in Ohio, where using a tool and approach for a local crisis system matrix, we've significantly amped up how we conduct that work and had some great success in working closely with local partners for their collaborating with their local partners to come up with a visible and accessible view of the behavioral health emergency services continuum in that county. And last but not least, the crisis response pilot, which is the 911-988 interoperability pilot that Cal is going to be speaking about now. So I will stop and turn it over to you. Thank you.
Thank you, Alicia. Hi, everyone. I'm Cal Jenkins, Assistant Director of Research and Evaluation with Clear Pathways. And like Alicia mentioned, I'm going to be talking about our crisis response pilot. This was a year-long effort that actually just wrapped up in August this year. And I'm excited to be able to share what we've learned so far, but also there's going to be a formal evaluation report that comes out in 2025. So we haven't learned all that there is to be learned quite yet. But jumping right in, we had 5 pilot sites throughout the state of Ohio. Oh, I'm sorry. Can you stay on the previous slide? Thank you. We had 5 pilot sites that were throughout the state of Ohio. Each were required to have a working group that minimally included a 911 PSAP representative, their local 988 provider, and their local behavioral health board. And the focus of these work groups was to work toward facilitating warm transfers from 911 to 988. And we landed on that focus because ahead of this pilot, we learned that it's the norm, or more of the status quo, that behavioral health call centers, including 988, do send calls to 911, but that the opposite was infrequent, that it's not the status quo that 911 can send calls to behavioral health call centers or 988 specifically. All right, next slide, please. All right, so our key activities. Before I jump into these, I just want to acknowledge that all of these key activities were heavily supported by our implementation partners at Dignity Best Practices, helping identify what these key activities ought to be, developing content to support these key activities, and being actively involved in all of the working group meetings. But starting here with number one, building consensus. So like I mentioned, each of the working groups minimally had representation from 911, 988, and boards, which all have their own perspectives. So we wanted to understand what their motivations were for participating in this work, what their local goals may be, and just ensuring that there's alignment within this group on their current state and where they want to be at by the end of the pilot. Number two, understanding each other's systems. So really helping 911 and 988 understand each other's current call flow and using scenario exercises to help exemplify what that call flow looks like in real world situations. But I can't speak enough to conducting site visits. Many of the participants in the pilot acknowledge that as an unlocking moment for them, being in each other's spaces, particularly 911, getting to see the 988 call centers, understanding that they're not sending calls into a void, that, this is a call center somewhat similar to their own call centers. And also this pilot was largely virtual. So the site visits provided an opportunity for folks to get together in person and, help also foster their relationships. Number three, analyze and identify call types. So essentially here, just using data to help the work group prioritize what calls may be appropriate to start with in terms of transferring from 911 to 988. So that looked like requesting a month of data from 911 and 988. And on the 988 side, looking at what kind of calls do you currently receive, and at what volume, and what percentage of calls are going to 911. And it was really helpful for the 911 partners to get to see the breakdown of the robust types of calls that come to 988 and the low volume of calls that they end up needing to send to 911. On the 911 side, there was an example coding completed to show all of the calls that could potentially have a behavioral health element, and working from looking at that like example dashboard, being able to decide, based on the calls we've identified that are potentially behavioral health related, where do we want to start with collaboration with 988? And then lastly, developing protocol. So steps 1, 2, and 3, all of these activities really built toward number 4 here. Each site, we developed a decision tree to help surface criteria for retaining or transferring calls. And then also using those decision trees for like the sites themselves to develop their own agency protocol, specifically PSAPs, developing protocol to transfer calls to 988. We also provided an MOU template at the end of this process such that all of the decisions made throughout this would hopefully be institutionalized by the participating agencies. Next slide, please. All right, like I mentioned, the evaluation is still underway, but these are just some quick lessons learned. Some of the key barriers: 1, liability concerns. That's definitely expected. It's not specific to our pilot sites. It's not specific to Ohio. But we did learn from sites that on the lower end, having state level guidance around liability, or on the higher end, state level legislation around liability would actually be something really helpful to alleviate that barrier. Also, staffing and training needs. There's, of course, the training needs to help actually facilitate call transfers, but there's also needs, for the folks showing up to these meetings to plan out what collaboration looks like. That's not really currently, to my knowledge, anyone's job. People are kind of having to step outside of their day-to-day to do this work. And so we appreciate the time that people spent on this, but it's certainly a barrier that they don't have much dedicated time to contribute to it. Key competing priorities and differing philosophies of 911 and 988. So this is just to acknowledge that 911 and 988 are fundamentally different services. And as you go into collaboration together, there's just going to be things that come up that are kind of complex to work through. I like to use the example that 911 calls are recorded and made public record, whereas 988 calls, if they are recorded, they're certainly not made public record. And if we're talking about a warm transfer where these folks are on the phone with a caller at the same time, there has to be a negotiation there between their priorities and philosophies. And so just acknowledging, even with great relationships and great intentions of making this work, you're still going to just run into these things that are somewhat unavoidable because 911 and 988 are fundamentally different. And so just acknowledging those challenges. There's so many things that come up, similar to the recording example that I just gave, due to 911's more public safety focus and 988, being more oriented toward privacy and confidentiality. All right, but on the key facilitator side, I know it sounds obvious, but regular meetings and ongoing communication is super important. It directly competes with the key barrier of staffing and training needs. But throughout the process, once folks did get into monthly meeting cadences and once folks would get together one-to-one to meet outside of work group meetings, it really expedited the process. And then lastly, I mentioned this in the last slide, but examining 911 and 988 call data together in working groups was super beneficial. All right, we can go to the next slide. All right, and this will be my last lessons learned slide before I wrap us up. So the last slide was really talking about barriers and facilitators to the warm transfers to 988. This slide is really more so much bigger picture and just talking about the way that Clear Pathways has oriented ourselves and when we talk about 911 and 988 working together. So when we started this work, ahead of the pilot in 2023, we really based this work on emergency communications interoperability. That's essentially the way that 911 agencies work together. That doesn't perfectly apply to the 911, 988 space, but there's so much literature and resources to pull from that it just gave us a good base to start from. Our goals were also defined by a tool called the interoperability continuum that lays out 5 different components of interoperability, and we selected 2 of those components to be our key areas. Those are governance and SOPs. So all the activities that I talked about earlier really fall into those categories. But moving into 2025, we know that there's been work across the nation happening with 911 and 988, and we've learned from our own work as well. And so instead of basing our work on emergency communications interoperability, we'll base it on emerging knowledge and best practices around 911, 988 interoperability. We'll still use the interoperability continuum to help inform our goals, but our goals will also be informed by the experience that we had with this crisis response pilot. And lastly, our key areas will keep governance. We're going to expand from just SOPs to more broadly policy and procedure, which is much more encompassing. And then lastly, training was not a key area we integrated into our work, and we want to integrate that into our site-facing work in the future. Next slide, please. And before we wrap up, just want to acknowledge our partners in this work. So of course, there's Pew, who you heard from already and then aren't pictured here, but appreciate their support for this effort. Alicia and I represent for Clear Pathways, an initiative of the PEGS Foundation. We also have Dignity Best Practices, who are our implementation partner, and Mathematica, who is conducting the evaluation for this project that will be out in 2025. Next slide, please. And I know Alicia is going to be representing for us at the roundtable, but here is both of our contact information for you all to have. So thank you very much.
Thank you, Cal, Alicia, and Julie. Just really appreciate the opportunity to hear how you all are having this partnership in Ohio move forward. And it's just so important that we do bring all these stakeholders together. Alicia, I know you were in the presentation. If there was anything else you wanted to share before I ask some questions?
The only thing I will share, and thank you again for the opportunity, and I always have to do this, much to Cal's embarrassment, but Cal is the key factor in this pilot being exactly what it was and conceived of the process and the tool that we could use, adapting the Department of Homeland Security's interoperability continuum, and then making it so that we could now have the results of our pilot to inform an interoperability continuum that's not just based in public safety, but also behavioral health. So always have to do that. Thanks a million, Cal, for the great work that you've done. The only other thing I will say is that Ohio is an 88 county, 19 988 center, 217 plus PSAP state, and we are home rule. So it's imperative that we consider the realities of Ohio when trying to understand first before regulating how 911 and 988 could collaborate. So this is important for us, and our hope is that the likely success of this work, as conveyed to us by the participants in our convening a week or so ago, which I see a lot of folks from on this call were actually in person with us when we unveiled a lot of the work that we're doing. Our hope is that we can encourage the development of some guidance for promotion of 911 to 988 collaboration and call transfers. The one other plug I want to make on the work that we've done is it's because of Pew and the very rigorous research process that we can have confidence in the work that we've done. So coming up with an idea of, oh, it'd be great if we could do a 988 or 911 988 call transfer pilot and see what that's like. But having first coming up with a kind of what's the logic model, what do we think it's going to accomplish, having a research plan and method, and then understanding the importance of having implementation partners and evaluation partners on top of all that really sealed the deal for us that this is the work that we need to continue doing, as Cal mentioned, not only in the current space, but ultimately in the training space moving forward. So thanks again, Laura and the Crisis Jammers, for the opportunity to talk about our work.
Yeah, well, thank you all for doing that work. And my first question as someone who is interested in the public policy side of things, and you mentioned the home rule, 88 counties, 19 centers. I see we have Doug Jackson from Ohio here, who serves as the 988 lead. And so wanted to see, like, what was that partnership working with the state? If you want to speak to that, or Doug wants to speak to that, how can others help? And is it important to have the state involved, or is this something that you all did without that connection?
It's very important. And Doug, I'm glad to see you come off mute. Please chime in.
Hey, yeah, I was not anticipating any spotlight, but happy to say that the work together, working with PEGS Foundation and the Clear Pathways Project, was not something that was a surprise to us. They talked to us in the very beginning about the idea of it. We engaged with Pew as well in some of those conversations. So just not being surprised is a starting place, but then the continued collaboration from there as to the communities that were identified to really represent, not just one type of community in Ohio, but a broad group of different communities in Ohio. That was important for them to walk alongside with where the state is at for both 911 and 988. So myself as the 988 administrator, but also the 911 administrator in Ohio. We were part of the conversations and updates throughout, and then recently even sat down at a kind of wrap-up session of all of those stakeholders who are involved in it to be a part of that conversation. What were the findings? Where are we going from here? So it's been a good process throughout.
Thanks, Doug. And sorry to put you on the spot there, but I saw you and I see another comment from another Ohioan in the chat, Mike Hogan. Didn't know if you wanted to make an additional comment around this project and why it's important to bring so many folks together and do it in a real organized way. Okay, we may be having trouble getting Michael unmuted. I also see that we have here Vibrant's own Director of Crisis Continuum, Amanda Miller, who specializes in helping folks connect, the 988 Lifeline and embed that into their crisis continuum. As our feature presenters mentioned, crisis contact centers within the 988 Lifeline do reach out to their PSAP colleagues, but sometimes the PSAP colleagues aren't always aware of their local 988 centers. Amanda, do you want to say a few words here? This is what happens when you put folks on the spot. Well, I think this is so.
Laura, I'll just jump in because I can't finally figure out how to do this. This is Mike Hogan, former Buckeye. I think the the project has kind of unveiled something that in a way was obvious, which is that this can't proceed entirely, that is 911, 988 collaboration, without some kind of infrastructure and guidance. And Cal and the team just did a great job of bringing people along, participation, obviously a carefully structured kind of process. We're not going to solve the connection needs of hundreds of 988 centers and thousands of PSAPs without some more consistent approaches like this. So it was a great effort.
Awesome. Thank you, Mike. If I could put one more person on the spot, because I also see a comment in here from just an amazing legislator, Representative Tina Orwell. Maybe talk to us a little bit about the work and help facilitating these conversations, particularly with the liability side of things.
Can you hear me?
Yes.
You know, this was a piece around liability that came up pretty early in our 988 process because, again, these two systems have operated quite differently. And we're kind of asking 988 in some ways to operate like 911, including our rapid response teams. And so we did a pretty comprehensive bill looking at liability, and happy to share it. But we got a lot of input from 911, 988, and our behavioral health system. Again, we want the clinicians and everyone working together in both 988 and 911 to know we're supporting their work. And it's new territory, right? So we want everyone to feel safe as they do this. And I think that has provided an important umbrella.
Thanks, Representative Orwell. This is important work. This is big items to get our hands around, and it will look different for every community. So I think it's so important that you all did that work to bring stakeholders together and really in an organized fashion, as mentioned, to address some of these issues and then codify it. It's very difficult, when there are thousands of PSAPs that has been mentioned, I think over 6,000 individual PSAPs, and there's not one overarching federal authority that can say this is the way it must be done, the way that 988 has SAMHSA to say this is, what we are all going to be aligned to. So I just want to thank you all for that work, Alicia, Cal, Julie, for helping to fund that. Any final thoughts before we move to the next segment? Any of our featured presenters?
Not for me, just thank you.
Awesome. Any final thoughts, Cal or Julie?
Just encourage folks to reach out to me, Alicia, or Cal to learn more about the work. We're happy to talk at any time. Thank you so much for giving us this opportunity.
Awesome. Well, let's move ahead to our SAMHSA update. We have Dr. Belina Shaw with us today. Dr. Shaw, take it away.
Good afternoon. I am going to share some slides, so I won't bother turning on my lights. But just wanted to update you guys on a couple of things this afternoon around SAMHSA. So the first I'll put in the chat is that November is actually Homeless Awareness Month, and the team has created a toolkit to that effect. Whoops, I did not send that to everyone. The team has put together a toolkit to that effect. And with Homeless Awareness Month, this is impactful and important because, as we know, people that are presenting in crisis don't necessarily always have a specific mental health or substance use crisis, and often they can be social crises, or the mental health or substance use crisis could be exacerbated by that social crisis. And so working with partners and homeless services is a really important part of what we do. And I just wanted to make people aware of that toolkit. There are specific dates with graphics and additional messages for the specific days that you can share with your partners. Let's see if I can share I also wanted to share about a federal advisory committee, actually, that we are engaged in at SAMHSA. Let me just make this. It's called, should go back, and Joel is not with us, but he is my co-lead in this work, the Interdepartmental Serious Mental Illness Coordinating Committee. It is focused on the needs of individuals with SMI and SED and how to coordinate care between and services and supports for these populations. And so just as we think about government and how one can get involved in government, some people that you know, I'm sure, are members of the ISMIC, but we have 12, and this is 12 federal members, spanning from CMS, Social Security, HUD, education, et cetera. So 12 federal members, and they are also joined by 14, statutorily 14, if I recall, non-federal members, but that's a minimum of 14 non-federal members. And they come together and work on a series of topics that are indicated in these graphical logos there. SAMHSA, we at the bottom there provide the operational support for these, we call these working groups. And Dr. Delphin Rittman is the chair and the body together of the non-federal members and the federal members together make up the ISMIC. And so the ISMIC has a couple of main elements, and I'm mentioning this because we actually have just released a new report, a 2024 report for the ISMIC, and Congress asked us to provide a summary of advances. A summary of research advances in SMI and SED, an evaluation of the effect of federal programs that have on these public health outcomes, and recommendations for actions that agencies can take to better coordinate the administration of mental health services for adults with SMI or children with SED. And this is the cover of the report. We have undergone some significant rebranding as well for the ISMIC because the ISMIC is not SAMHSA. So SAMHSA's main primary color is blue, but we wanted to focus on some purple in there to indicate recovery. And this is the title of the cover, the report. We have also now revealed a new emblem for the ISMIC. It's purple with focusing on recovery. The outer ring obviously holds the title, but there's also this inner ring, and the inner ring here has three figures that we are representative of individuals that are in community together and have arms that are connected to the services and supports that are indicated by these rings here, the rings. Each color corresponds to the 5 working groups. Our 5 working groups are data and recovery, treatment, data and evaluation, treatment and recovery, access and engagement, criminal justice, and finance. And we actually have stewards that support the working groups crossing both SAMHSA and now the Veterans Administration is supporting as well. And so I just wanted to, actually, this is a great example in this presentation of sort of how the work has translated from the research to science, that the RAISE, the Recovery After Initial Schizophrenia Episode, is a major study that was done by NIH, created this EpiNet network to continue to build upon the research, created this coordinated specialty care model. Then the block grant set aside based on advocates was built in to be able to support funding the coordinated specialty care model, and that there's been a broad expansion. We've done a paper on the financing and the broad expansion of coordinated specialty care across the community. There's just an example of how SAMHSA has taken research and translated that to the breadth of services in the community. CCBHCs, et cetera, are all really important. What I also wanted to get to here is that we have a set in this reports. We also have a set of recommendations, and I don't think I was savvy enough to have the recommendation for 2.1, although I have graphics that animation's not quite necessary. Like for example, recommendation 2.1 is focused on crisis care and creating and defining a definition and standard for crisis care. And John Palmieri, as you guys all know, and I and Jill Mays have been working on that work, and he'll present on the status of that next week and give you a little heads up about when the public comment period will be opening. And here's an example of the actual recommendations. The last was a summary of some of the activities with some of the outcome or at least process measures from the inventory of relevant programs. So crisis care has been a significant part of this, and I mentioned this here because not only did we have a meeting last week at SAMHSA's headquarters, our first one in person since the pandemic, but I really do believe, and I've heard David Covington say it before, that really having this document and these recommendations that have spanned from 2017 on to say that developing the standard for crisis care, expanding crisis care, have really been probably an unsung hero in the expansion of the work and really helping to catapult 988 out from the National Suicide Prevention Lifeline and the ongoing catalyst of down the line service delivery. And there's some description of some of the progress that's been made on the recommendations as well. So we do have a quarterly ISMIC newsletter, and there will be another ISMIC meeting. The ISMIC meetings are public. They are available via telephone for the public, and you can provide public comment. And we do read them, or if you don't want them to be read, they can be part of the public record. But we do really consider them. We actually changed some of our presentations based on the public comment that had just come in, and making sure that we are responding to the public as part of this federal advisory committee. So that is just a little bit about our advisory council at SAMHSA, the ISMIC. And I just wanted to give you a little update of some of the work that's been doing, and it was great. Yes, David, do you want to say what you're saying in the chat?
Yeah, Belina, I just thought the work that ISMIC has done over the last, going back to 2017, definitely helped lay the foundation for 988 and the national guidelines and the revision you're working on. It also really helped forge this even stronger partnership between feds and states around crisis care. Of course, Dr. Brian Hepburn involved from the beginning, but also now a member of ISMIC. It's a great effort. Really have loved being a part of it.
We appreciate both of your energy and efforts in it. We call you the OGs of the ISMIC. You guys have been with us since 2017, and we are appreciative of your consistent service as well over the years. Sam's update.
Awesome. Thank you, Dr. Shaw. Really appreciate that update. And folks, please do make sure you take a look at the chat. It is chock full of resources, links. So thank you, Dr. Shaw. Going to move on now to NASHBID, the National Association for State Mental Health Program Directors, and their update from their Executive Director, Dr. Brian Hepburn.
Thank you, Laura. As always, you do a great job of facilitating, so thank you. Thanks for the comments from David, and also Belina and the work at ISMIC. As David has said, it's made a big difference and provided that leadership. I wanted to say a little bit today. I'm going to talk briefly, but I just wanted to say a little bit today related to the election. We know that it's been a difficult time for many people. There was a lot of stress leading up to the actual election, and then we know this morning there are some people that are more stressed. So it makes me really reflect on the crisis services and the fact that we've all been pushing for increased availability for crisis services, and wanted to thank the leadership of SAMHSA, Belina, the 988 team, Dr. Delphin Rittman have been great at providing leadership so that when you look at the crisis services availability. We have more crisis services available than ever before. And I do want to say something about David Covington. David has been one of the leaders that has really helped expand crisis services, the call centers, mobile crisis stabilization. So it's important for us to look at the funding and sustainability, making sure that all these good things that are going on will be sustainable. And it is important to reflect on the fact that the one-time only funds like the American Rescue Plan funds, COVID supplemental funds, they were all very helpful at helping support 988 crisis services, allowing us to move ahead. But then we have to have sustainable funding. And the sustainable funding has come from CMS through an enhanced match for crisis services, through the block grant of SAMHSA, but also through fees. And I did want to emphasize a little bit that we've been working with states to develop a template that they may be able to use, an updated template that they may be able to use for their own legislation for fees. And we're looking to those states that have been successful at developing fees, at implementing fees, to be able to help some of the others. Because although earlier there may not have been as much interest in fees, as states look at how much money is needed to sustain and looking at the braided funding in order to be successful, there may be another opportunity to get fees passed in states. So we're hoping to renew that effort. So with that, I'll thank all of you for your service and for the work that you do. And this is a journey, or the movement. We're just a few years in. We've got a number more years. Some estimate another 10 years, so that we really have good penetration. But we're only successful if we all stay engaged. And I just want to leave you with the fact that so much of this work has been bipartisan. We really expect that the work will continue and will be successful. So thank you.
Thank you, Dr. Hepburn, and just want to say a few words about your leadership. Just really appreciate the work that comes out of NASHBID, all of the papers, the model legislation. You all are really at the forefront and very helpful in ensuring that the states are a part of this. So just want to thank you as well. Okay, so let's keep moving forward. We do have a very robust tech corner. So I'm going to turn it over to Dr. Tina Soma.
Thank you so much, everyone. My name is Tina Soma. I use she, her pronouns. I'm a research scientist and clinical implementation consultant over at Listen. Today, I'm going to be very briefly talking about AI bias. Next slide, please. I want us to first ground ourselves in thinking about AI as including a continuous evaluation and constant quality improvement. As we're building our models, our data will have some kind of interaction with humans, whether that be data curation or, for example, in the behavioral and mental health spheres, we have humans who are annotating and coding data for different types of mental health behaviors or interventions. That gives us, next slide, please, what we call our ground truth. This is the basis for the data that's used to train our models and the pattern recognition that our model learns. The issue here is that the humans annotating the data carry their own identities, contexts, and lived experiences that influence the data. What can happen, next slide please, is that we see AI bias emerge in things like mental health behaviors or medical diagnoses that are identified by AI models. Given that every AI model contains some kind of bias then, next slide please, I want us again to lean back on the fact that AI is about constant and continuous evaluation. So as we change as humans, our contexts change, our environments change, our models need to change with us. So what we've done in an attempt to control for bias is to conduct bias studies. So over at Listen, what we've done is after collecting data, We have provided bias and multicultural trainings to our human annotation or coding teams. We've attempted to remove some kind of features of the data, like audio or video, that might have some kind of bias in the coder's interpretation of the data. That human annotated data is then run through our models, and we compare the human annotation to our model ratings. We do these comparisons with a general population and then the subpopulations that we're examining bias. So that could be based on race, gender, or first language preferences, for example. If you're curious about how an AI bias study could be conducted, we publish an annual AI bias report that's available on our website, and it's linked as a PDF below on the slides. So thank you so much for your time. It's a pleasure to be here. You all are doing incredible and really important work, and we're always here to support the continuous evaluation and quality improvement so that the work that we're doing continues to get better. So thank you so much, everyone.
Thank you, Dr. Soma. Appreciate that. And if anyone wants additional discussion around AI, make sure that you go back to the Crisis Jam and take a look at the vigorous debate that was around AI in crisis services. But I'm going to move us forward because we have a wonderful guest here with us today, coming to us from Australia, where I think it is 4 a.m. You can correct me on that if I am wrong, but please welcome Sue Murray, who's going to talk to us around South and Southeast Asia mental health crisis care. Sue?
Great. Thanks very much, Laura. And thanks everyone for allowing me to join you today. Yes, it is very early in the morning, but I'm always happy to be here. Look, this week's Crisis Talk article, it's really was prompted by discussions that we had at the Zero Suicide International Summit, the 5th International Summit, and then the third Crisis Care Summit in Amsterdam. And it was really after hearing discussions from our colleagues in Asia about some of the challenges that they face in terms of providing crisis care. So that was the prompt for this article. And I think I had the opportunity to interview colleagues from Malaysia, from Indonesia, and from Bangladesh. And I think the first thing that struck me, of course, was just the sheer numbers of people that the Asian communities are having to manage in terms of crisis services. And I think across those three countries, there was sort of the landscape for mental health crisis care was really shaped by the cultural beliefs, the healthcare infrastructure or lack of infrastructure, the policies and the access to services. Indonesia was interesting because they really have very little by way of policy infrastructure that helps to guide their services. They're also a deeply religious country in that Dr. Oni, who I spoke with, said that really people would prefer to talk with their imam, their pastor, their priest before they would think about seeing a mental health professional. And they also do have a real deep culture of caring for their neighbour. So they've tried to pivot and focus their support services around building community capacity. But there are some real barriers in regard to structural deficiencies in the healthcare system that really do hinder their crisis care delivery. Bangladesh was completely the opposite. They have very strong policy direction, and it was 100 years between when they created their first Mental Health Act and they updated it. So that was only done back in 2022. So nearly 100 years before change in their legislative direction. But the challenge for Bangladesh, of course, is they have lots of policy, but largely the population of Bangladesh is illiterate in regard to their policies. So they've got a really long way to go. But of course, they too rely very much on the community volunteers and the family support And they're really looking to strengthen their primary healthcare system by training psychiatric medical doctors to also provide some mental health healthcare support. And then Malaysia, I think one of the things that struck me about Malaysia is that they had really only just decriminalized the act of attempted suicide back in 2023. So they're really creating a major shift in their country about how they will manage crisis services. They also have very
I'm going to
limited.
have to interrupt you
Yep,
just for one second. I'm so
cutting
sorry.
down. Oh, sorry.
No,
Get
you're
over,
okay
get
because
over
we're
to
right at
crisis
time,
call.
but I do want to direct everyone to read the article because there's really great information in there. And thank you for
Thanks,
joining us
Laura.
so early. No problem. All right, guys. Well, we are coming near the end of this jam, but don't worry. Next week, we're going to learn about California services and evaluations from Dr. Mark Saville. And then the week after that, we're going to learn about intersections of indigeneity for indigenous populations and queerness from Jericho Cummings of Pathways Remembered or Paths Remembered. Really great. And then we have another debate coming up for crisis and peers. What is their role in crisis services, right? Are they incompatible or are they a core component? So this was a conversation that took place in Amsterdam. We will have that for you coming soon. So thank you all for joining us so much this week. Appreciate your time. Thank you for watching. Check out the resources on talk.crisisnow.com.